Good morning, you guys. It's currently 5:14 in the morning and I just got down here to start working. So I'm about to just plop you guys up here on my desk and then we are just going to get into it. So if you haven't watched any of my other day in the life of a medical coder, you know that the very first thing that I do is I check my my emails very first thing in the morning, and then I just either jump in to review some denials or I will begin coding, whatever I feel like doing. I might look at some denials first, or you know what, I might actually just start coding this time and then look at my denials later. So let's get into it. Okay, I decided I'm going to look at my denials, and yay, I only have 3 of them. So, and the reason why I only have 3 is because I basically did all, I did all my denials on Friday that I had, and I think I might have had like 11 or 12 in there. So over the weekend, only 3 popped in. So that is lovely, because sometimes these denials can get crazy. So my first denial is for a 99468, which is the first inpatient critical care per day code. And I'm reviewing the diagnosis codes. And then I'm also going to review any comments that Patient Financial Services, or PFS is what we actually call the department, to see what they said is the problem. Okay, so it looks like they reached out to Blue Cross to say, please provide more detailed explanation of denial for CPT code 99468, which specific diagnosis is being denied. And they responded back and said, we have reviewed your request regarding claim number blank 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 to verify the denial. Diagnosis code J93.9 is not typical for a patient whose age is 0 days. Typical age range for diagnosis J93.9 is 29 days or older. The J93.9 is what they are denying this for. So I'm going to make a correction to this claim, and I'm just going to go over there and look at this J93.9. I doubt it's going to say that it's not to be used on patients 0 days, but I just want to see what information my book would have given me. J93, yeah, nothing. It says nothing about not using it on the newborn record. Okay, so you guys just saw that there was, why is my phone moving? Okay, so you guys just saw that there was no indicator telling me that I should not have used this code on this newborn record. I'm just going to remove it. And I did want to say that I actually don't review or code all neonatology E&Ms. I only review procedures for neonatology. So if a baby or a newborn is getting like a hearing test, or if they're getting a circumcision, or if they are having a PICC line insertion, I review those things. But their regular E&Ms, like their everyday, their first initial hospital visit, I don't review that. Any subsequent visits, I don't review. Discharges, I don't review. When they're in NICU, I don't review any of those E&Ms. So this one most likely had just went through, and now it's coming back, and I have to review it because they don't have anybody to review their E&M denials. My next denial is for a mutually exclusive procedure, and the CPT code is 99464. And it looks like for this data service, we're billing the attendance at delivery, and then we're also billing the initial H&P code. So let me just make sure I only see all the CPT codes that were billed by my department on this specific data service, and it was just those two. So I'm going to send this back over to Aetna Commercial Team 2 and let them know that this was billed correctly and that the attendance at delivery is a separate service than the initial H&P. The attendance at delivery CPT code 99464 is separately billable. Actually, I'm gonna say is billed separate from the initial hospital care charge. 99221, please. Okay, so I have please send back to insurance. The attendance at delivery CPT code 99464 is billed separate from the initial hospital care charge 99221. All right, and then my last one is also for neonatology, and it's going to be 99387. Oh wait, no, this is not neonatology. This is actually a office denial. They actually paid partial. Yeah, it looks like it was an annual well visit. So they allow $109 out of this $261 charge, but they only paid $89 for it. And they're letting me know that this was underpaid. So I have a comment here. It says, Medicare paid the new patient procedure, but now it has changed to a preventative code, which Medicare never pays. That's why we usually bill the G and Q code instead of preventative code. Can this be changed back to an E&M code? I actually do not review their office E&M, so I will have to let them know that they need to send this to the office, and then the office can reach out to our claim review analysts if they have any questions on which CPT code to bill, because I can't give any guidance on their E&M levels in the office. They have to choose those on their own. So I'm just going to transfer this back to Medicare denials team. Okay, routed to wrong work queue. Medicare, please send to OB/GYN office for review. I do not review their office E&M services. Okay, I have here, please send back to my OB/GYN office for review. I do not review their office E&M services. Please inform them to reach out to our claims review analyst if they are unsure of the correct CPT code to bill. Thanks. And that's done. So those are all 3 denials complete. And now I can jump over to a different work queue. Okay, I can fix this one. It's just a diagnosis code error. So I'm going to look at the documentation to see if I can get a more definitive diagnosis code. I had a charge that was holding because they used the weeks of gestation as the primary diagnosis code, and that cannot be the primary diagnosis code. So I just added in that Z3401 for encounter for supervision of normal first pregnancy. Correct diagnosis codes. So now that I fixed that one, my ultrasound should be able to go out. All right, it's gone. And then this one. Okay, so my next denial, not a denial, my next claim edit, intubation 31500, that is holding in my work queue, but 99468 had already went out. And if the intubation happened in the NICU, we cannot bill for intubation inside the NICU. You can only bill for it if it's an emergency, like right after delivery. That's the only time you can bill for an intubation code on a newborn. But if they're doing it in the NICU, you cannot bill for it because it's included. I have to review the documentation to see if they did it in the NICU or they did it at attendance at delivery. Okay, yeah, it looks like this might be an emergency intubation. Actually, I think I reviewed this one last week. Yeah, yep, I reviewed this one last week. So let me just check that data service. 5/13, so the baby would have already been in the NICU because they admitted them to the NICU on 5/11, and now they're billing for this intubation on 5/13. So we cannot bill it, and I have to change this charge to a no charge. I had to think about what you're talking about. I feel like they should have something for new patients because it's not right that all the providers, or our providers, if they're seeing them the very first time, they can't bill a new patient. Okay. Bye. That is so funny.
I bag it up. Tell all my hoes. I tell all my hoes.
What the hell did they do to this patient's insurance? Okay, we're in 2021. And her insurance lapsed 12/31. So let me figure this crap out. This is the fun part of OB, having to figure out insurances, and when the patient's insurance changes throughout her pregnancy, you then have to look at how many visits she had. You have to bill out visits to one insurance versus the other insurance. It becomes a lot. So this patient's very first OB visit was 9/10/2020, and she has high mark. That is termed on 12/31/2020. So our first visit, and then we have one second visit, third visit 12/29. So we have 11/30/2020, and then 12/29/2020, right? She only had these three. Okay, so then after 12/29, all these visits I have to send back to the provider to pick an E&M because they picked the 0502F because they have insurance in her, like in her chart, but it shows that it's inactive. And the front office staff at the practice are supposed to be checking insurance when you come in to make sure that your insurance is active. And it must have slipped their minds to check that day. So we need to send all these, I want to say they're like the global delivery charge, because it is like the charge that it's not a charge, it's just the code that you submit because you're planning on billing for her entire pregnancy at the time of the delivery. So we use these category 2 codes, the 0502F, just pretty much for like tracking purposes. And now we need to send all these back for E&Ms. Yikes. So, all right, so I originally had billed global 59400 for her vaginal delivery, but it looks like I'm gonna have to change this to the vaginal delivery only and postpartum care, so the 59410, and then the office has to correct all these 0502Fs that they submitted. But because this is not my practice, I don't know if I said that in the very beginning, this is my coworker's practice. Sometimes my providers will deliver her patients because we are all considered one group. So I don't have to like send her to the delivery. If my provider delivers her patient, I can bill it because my provider did it. And any office stuff though, like insurance issues or anything like that, we do communicate with each other and let each other know, like, hey, you might want to reach out to the practice to fix this, because we don't fix their E&M stuff or their office stuff. I mean, we can fix it, but we're not supposed to choose the E&M levels for the providers in the office. So I'm going to let her know that she needs to reach out to the office for this patient, because these visits, these prenatal visits, are a mess. Please reach out to are all messed up because okay, what do I have next to look at? See why these charges came back to me. Oh my gosh. United Healthcare, they don't bill global. They only UPMC bills global. So now these visits also need to be sent back. What is going on? What is going on? Okay, so this patient had Blue Cross 1025 to 228. Okay. And this is for 2-8. And then we have 3-3. Okay. Another patient with different insurances. She went from Blue Cross out of state, which is a commercial insurance. And then she went to United Healthcare Medicaid when she was 35 weeks. So all those beginning visits need to get billed out, and I wonder if she billed them out. So 11/30/2020 should be 0502F. I'm going to put a question mark just to check her appointments and see why she came into the office that day. because the diagnosis code is not supporting an E&M. So I don't even know why we build an E&M. This is so confusing. So Blue Cross was effective 10/25/2020 through 2/28/21. And then United Healthcare was effective 1/1/2020 to present. And this is United Healthcare Community Plan. So now that I have the insurance written down, this shouldn't be that freaking confusing now. Where's her first visit? Right here, 9/2. And then the one after that, Blue Cross was effective 10/25. So we have this visit is correct for 9/14. 10/19, this visit is correct. So then she picked up Blue Cross. So this 11/30 visit should be the 0502F. So I need to correct this one. Looks like somebody corrected this one. She said she corrected this back to the E&M. But why? It started, oh my gosh. Okay. First Blue Cross visit was 11/30. This is the first one. And then she had one. Okay, so she corrected that. And then looks like 1/11/21. Looks like, oops. 2/8/21. 3/3. Okay, there it is. Okay. So it looks like she already billed those visits out, so thank God. Hey guys, it is 9:50. So it's almost 10 o'clock and we are almost halfway through our day. Yay! I love starting so early because doesn't that sound crazy? Like I'm already halfway through my work day and it's only 10 o'clock in the morning. I seriously feel like I worked all day. I know I've been like in and out talking to you guys here and there, but I feel like my day needs to be over soon. And it's only 10 o'clock in the morning. But yeah, I'm just gonna head back to finish up working or finish working, not finish up, but I'm gonna finish working and I'll continue to pop in and out when I'm talking about work stuff. Okay, so I have my first vaginal hysterectomy that I'm going to review for today, and I figure why not share with you guys so you guys can listen in on how I build a vaginal hysterectomy. It looks like the patient's coming in with history of chronic pelvic pain, left lower quadrant pain. The patient now presents with definitive management with hysterectomy, bilateral salpingectomy, and left oophorectomy after discussing therapeutic alternatives. And this was a scheduled procedure, so we will not be billing any E&Ms prior to the surgery, or like for her admission, I should say, because they would have billed a pre-op exam type E&M. But once she gets to the hospital for this procedure, we are not billing anything for like the admission to the hospital. So I'm looking at the pre-op and post-op diagnosis codes. They are the same. Those diagnosis codes are pelvic pain, which is R10.2, and post-endometrial ablation syndrome, which is N99.85. And my procedure details is pretty lengthy. So I will pull out what I feel as though you guys should pay attention to when you guys are reading op reports. And there was a resident on this, so I have to add them as the service provider because we are a teaching hospital. And I have to add the GC modifier. So I like to go all the way down to the bottom of my note because that's where the resident's name would be. If I don't go all the way to the bottom, I could miss it. And we have to use the residents as a service provider with my provider as the billing provider and the GC modifier. Okay, so the beginning of my operative report reads, patient brought to the operating room, correctly identified and procedure verified. They did some exams, placed in the lithotomy position. Foley catheter was placed. That would be included in the vaginal hysterectomy charge, so we do not bill that separate. And a con uterine manipulator was inserted. They'll stick this manipulator up there when they're doing a laparoscopic procedure. That way they can just manipulate the uterus as they need to. And then it says outer gloves were changed and then turned to the abdomen. So once they got done from being down in between the patient's legs, placing the catheter, putting the manipulator, the uterine manipulator up there, now she's going to change her gloves and she's going to move to the abdomen because she's going to be placing or making some small incisions for the laparoscopic procedure, which is with a small scope. So they're going to be able to do this procedure through small 0.5 centimeter incisions instead of having a open abdominal procedure. So they like to say like these laparoscopic procedures are less invasive because they can do them from small incisions. So let me see here, 0.25%. I cannot say that word. Bupivacaine was injected beneath the skin, and the infraumbilical 0.5 centimeter incision was made with the scalpel. So whenever you're reading a laparoscopic procedure, make sure you see that they are making small incisions, and then they should also be placing trocars. So the abdomen was insufflated on low, meaning they are putting oxygen into the abdomen. And let me see, 5 millimeter blade trocar was placed just below the umbilicus. And there was another port placed. And another trocar was placed. Usually there's about 3 incisions made. The left tube and ovary were ligated and cut with ligature device, starting with the distal portion of the fallopian tube, mesosalpinx, followed by the utero-ovarian ligament, and then the infundibulopelvic ligament. So when they take those 3, or when they document those 3 things, especially the infundibulopelvic ligament, when they remove that ligament, they're taking the tube and they're also taking the ovary. So whenever you see that term in your vaginal hysterectomies, know that the provider is taking both the tube and the ovary. If they only mention that they ligated the mesosalpinx, then they're only taking the fallopian tube. What else? And that was all done on the left side. And then it says the right distal fallopian tube was ligated and cut in similar fashion. The left tube and ovary were removed through an endo-catch bag through the 1 centimeter suprapubic port site. The right tube was removed separately. So, like I said, they didn't mention the infundibulopelvic ligament on the right side. So that ovary is still there. They only took the right distal fallopian tube, and then he said, or she said, that she removed the right tube as well. We have the tubes taken out, and then we have the left ovary taken out so far. And then I'm going to keep on reading. Okay, this is very, very interesting. Man. Okay, so then after they took the right tube, it says a Carter-Thompson device was utilized to place a 0 vicral suture through the fascia, which was tied. Why can't I read today? Oh my gosh, I always get tripped up on my words. It says 4.0 Vicryl was then used to close the skin in a subcuticular fashion. 4.0 Vicryl was used to close the skin in a subcuticular fashion. The abdomen was desufflated after thorough inspection demonstrated complete hemostasis, and then attention then turned back to the perineum. So this is so exciting, you guys, because when I first read this, sometimes my providers, they'll choose an op note, but you have to read the details in order to know what you are billing for. So we did everything up top in regards to like the tubes and the ovary that we took, but now we're heading back down below. So this is going to be a laparoscopic assisted vaginal hysterectomy. Hope you guys understood that. We are now looking at the laparoscopy surgical with vaginal hysterectomy. And LAVH is what the abbreviation would be for this procedure. So I'm going to keep on reading. Weighted speculum was placed in the vagina, incised with a knife. Uterosacral ligaments bilaterally were clamped, cut, and doubly suture ligated. Speculum was placed in the vagina. The cardinal ligaments were bilaterally clamped, cut, and double suture ligated. The uterus was then exteriorized, and remaining round ligament and broad ligament on the left side doubly clamped, cut, and tied, as well as the suture ligated. The right broad ligament, fallopian tube, utero-ovarian ligament complex was double clamped, cut, and tied, as well as suture ligated. Vaginal cuff again sutured. Vaginal cuff angle sutures were placed, incorporating the uterosacral ligaments. A McCall suture was placed, but not initially tied. The bladder was drained with a new Foley catheter, and clear urine was noted. The anterior peritoneum was suture ligated, and posterior peritoneum with a 3-0 Vicryl using a four-corner technique. This did effectively keep the bowel above the vaginal cuff. The vaginal cuff was then closed. Good hemostasis was noted. The McCall stitch was now tied, elevating the vaginal cuff. All instruments were removed. A vaginal pack coated. The surgical lube was placed in the vagina. Attention was then turned to the abdomen. Through the remaining two ports, the abdomen was insufflated and inspected. Good hemostasis was noted throughout. The abdomen was exfoliated gradually, while the left lateral port site was removed and directly visualized by endoscope. It was noted to be hemostatic. So any of that checking to make sure there was nothing wrong, making sure we have good hemostasis, all that checking at the end is included in your procedure. So you would not bill for that portion of the op note. And then they removed the other port. Remaining two port sites were closed. Patient tolerated procedure well and was taken to a recovery room, awake and in stable condition. She had a normal appearing uterus, fallopian tubes, and ovaries bilaterally. Normal appearing vulva and vaginal mucus, 1 centimeter inclusion, cyst in the lateral mons pubis, normal liver edge, gallbladder was surgically absent. All right, my coworker just got back to me to go ahead and bill global for that one we were talking about earlier with the prenatal visits being messed up. So my diagnosis codes, actually my procedure, because we only did, Okay, so for this laparoscopic assisted vaginal hysterectomy, it would be, well, let me see how much this uterus was, how much it weighed. Where's my pathology? Okay. Her uterus was only 80 grams. So we are going to be looking at 58552. But I just want to read and make sure. 58552. Because I'm pretty sure they were supposed to start cutting the like the uterine ligaments. I'm pretty sure they're supposed to start cutting that up top and then finish those down below, but we only did the tubes up top, so I don't know. I have to read this the explanation to the procedure in my OB-GYN coding companion book. I love to use this book to kind of like help me when I'm trying to figure out what all the providers is supposed to be doing in the procedure. So I'm getting ready to read through this really quickly. Yep, it says it right here. The round ligaments are ligated and incised, starting on the left round ligament, and the vesicouterine peritoneal fold is incised, and the peritoneal vessels are dissected and desiccated. The physician continues the incision across the lower uterine segment to the round ligament on the other side and dissects the bladder off the uterus and cervix. Staples are inserted through one port on the side to be stapled or bipolar coagulation until unit is inserted for electrocautery. At this point, if tubes and or ovaries are to be removed, the infundibulopelvic ligament is now ligated lateral to the ovary. If not, the ligation is done medial to the ovary. But it doesn't say when they changed their approach. So in my coding companion book, it doesn't even mention them switching from their laparoscopic approach to vaginal. So let me see what Select Coder says. Group notes we have in here. LAVH includes laparoscopically detaching the uterine body from the surrounding upper supporting structures. The vaginal portion of the procedure is then performed. Yeah, see, he only removed the tubes. I keep saying he, she, whichever one it is, only removed the tubes from up top. So let me see if I have the procedure that I've reviewed before. No, I don't see it in there. So I need to look at, is a vaginal hysterectomy. Okay, so I just put my codes in Select Coder looking at 58260 for vaginal hysterectomy for uterus 250 grams or less. I did not use any of the removal of tubes and ovaries because we did not remove them vaginally. We removed them laparoscopically. So I believe we need to be looking at 58661. And I put them in there in Select Coder to see if there was any excludes. But there was not. I had green checks, so that means they are good to be billed together. And this insurance is Blue Cross. So I have to look at my billing bilateral services for Blue Cross. And it says CPT codes should be entered on 2 separate charge lines with modifier 50. On each line, keep unit as 1 for each line. We need to bill 58661, modifier 50, 58661, modifier 50, and then where'd my vaginal? 58260. And then I can't forget my GC modifiers. That was very interesting because it went from me thinking we were billing a laparoscopic. Well, first of all, I went from thinking we were billing a total vaginal hysterectomy to a laparoscopic assisted vaginal hysterectomy to now we're billing just a vaginal hysterectomy with laparoscopic, with removal of adnexal structures, partial or total oophorectomy and or salpingectomy. And it does not say this is a bilateral procedure, so that's why I'm billing it twice. Bilateral fallopian tubes. There were follicle cysts. Where's my diagnosis for follicular cysts? That's going to be N83.0. And then I have to see which one was it. Hey guys, it is now lunchtime and I'm sitting here eating some leftovers from last night. This is some goulash that I had made. And I'm also about to watch a webinar on the AAPC's website so I can get my 1 CEU. I do have a video showing you guys how I obtain or how I get my CEUs to be able to keep my certifications that I have through the AAPC, because once you pass the exam, you have to get so many CEUs in order to keep your certifications active, or in order to keep them, period, or you'll lose them. But yeah, so I'm gonna watch this. This video is going to be an hour long, and then I have the little test at the end, and I'll be able to get my certificate for completion. And then when you do webinars on the AAPC's website, it automatically adds your CEUs to your tracker. So I won't have to do anything else from there. But I do like to take a snippet of my certificate and just save it in like a Word document and keep it for my own records, because they do audit people just to make sure that their CEUs are legit. But yeah, this video is an hour long and it is 11:42 now. So I'll be done probably about 1 o'clock-ish, because I do have the test at the end. And then I think at 1, I will only have like 45 minutes left of work. So the day is moving right on along, and yeah. Hope you guys are enjoying the video. Make sure you guys like it if you are, and subscribe if you've been watching me for this long and you have not hit the subscribe button. I mean, hello, what are you doing? But yeah, so I'm about to watch this video and I will pick back up with you guys a little bit later. Okay, so I just finished that webinar and I have, how many questions? 5 questions to answer. They look very, very simple. So I'm going to answer these and then get my certificate and save it like I said I would. And then I just have a few procedures that I have to do, and then we are going to be done for the day because I only have, 40 minutes left. So I'm going to do this and then do those last few procedures and we're done. Yay! It is 1:05 right now. I think I have 1 surgery and then I might have like 2 or 3 deliveries to do. But let me see here. Patient admitted to hospital with brief history of family history of ovarian cancer, abnormal genetic screen showing increased risk of Lynch syndrome. Patient presents for total laparoscopic hysterectomy with Da Vinci with bilateral salpingo oophorectomy after discussing therapeutic alternatives. So that's telling me total laparoscopic hysterectomy. That's our TLH abbreviation with a BO. No, with a BSO. That is the abbreviation for bilateral salpingo oophorectomy. Okay, so let's read this procedure note. Cervix grasp with single tooth tenaculum. Cervix was very difficult to dilate, but a V-care cup was attached to the cervix. Bladder was drained using Foley catheter. Examining the abdominal pelvic organs, there were significant adhesions between the omentum and the anterior abdominal wall all the way down through the pelvis. Uterus was densely adhered to the anterior abdominal wall. Ports were then placed laterally on direct visualization, and the robot arms were then docked to the ports. We released the adhesions between the omentum and the anterior abdominal wall. as well as to the uterus. So him leasing these adhesions to basically start his procedure is included. So you can't bill licensing of adhesions and bill for your hysterectomy. The uterus was then manipulated to be able to excise the adhesions between the uterus and the anterior abdominal wall as much as possible. Left round ligament was isolated, fulgurated, PK cautery, and divided. Anterior leaf. The broad was entered then. Infundibulopelvic ligament. Left side was isolated, fulgurated, and cut to remove the left tube and ovary. The broad ligament was then opened down to the level of uterine artery on the left side, and the uterine artery was cauterized. On the right side, the round leg was isolated, fulgurated, and cut. Infundibulopelvic ligament on the right side was then isolated, fulgurated, and cut. Right broad ligament was opened down to the level you are to the right side. The glove was placed in the vagina. Colpotomy incision was started anteriorly. So now we're cutting around the vagina to remove the cervix and the uterus, and then we're going to close the cuff. So closing the vaginal cuff, meaning the cervix is gone. Uterus was enlarged with fibroids, so it was very difficult to remove through the vagina. Uterus actually had to be bivalve to be removed from the vaginal opening. After the uterus tubes, ovaries, and cervix was removed, the vaginal cuff was examined and noted to be hemostatic. The vaginal cuff was closed with a running V-lock stitch from the left to the right side and back left side. Dense abdominal and pelvic adhesions, uterine fibroids, and abnormal genetic testings. Those are our findings. But I would have to go to pathology to get my diagnosis codes. So this procedure was a TLH BSO, and that's going to be 58570 through 58573, depending on how large or how much the uterus weighed. So I have to look at pathology to determine that. He did say there was fibroids, but sometimes they don't weigh that much. Okay, so this one weighs 264 grams. Yay, so we get to build a bigger code. So we are going to be looking at 58573. 58573, because we also removed the tubes and the ovaries. And let me just see if there was any other diagnosis code. Okay, so there is a benign fibroid for the left ovary. And it looks like there's also a fibroid in the endometrium, in the myometrium. All right, so I just finished that surgery and sent it out. So let's look at these deliveries real quick. I only have 2 deliveries that I have to look at. Actually, it's not 2 deliveries. It's the same patient, but I have 2 charges for her. So it looks like it's 2 charges in here, but for one patient for the 7th, May 7th. But yeah, it looks like I only have this 1 delivery to do, and I should be finishing up right on time. So let me look at this delivery and see what we have here. Okay, perfect. And my provider's actually seen this patient throughout her whole entire stay. So I don't even have to worry about checking for providers from my coworker, since we are all the same group. It was just, she was only seen by my practice in the hospital. All right, so let's see what happened when she came in. Sometimes I like reading these deliveries for people that have like surprise babies. So when they come in, they'll obviously tell the nurse or whoever they see that they don't know the gender. So like when I'm reading the H&P or the progress notes, I can see like it's a surprise delivery. So then when I get to the delivery note, I'm shocked too. Like, oh my gosh, what's gonna happen? What's gonna come out? As I'm reading, and I get excited because they don't know and I don't know. So when I'm reading, whether it's a vaginal delivery or a cesarean delivery, I'm just like waiting, imagining that I'm in the room. Like, what's it gonna be? And it's so exciting to see like, oh wow, they had a girl or they had a boy, and it's just like, oh. And then on to the next note. But anyway, this patient is 25 years old. She is 41 weeks pregnant. So we have a post-term delivery. And I need that Z3A41 diagnosis code. Let me see if there's anything else I need. Presents with no chief complaint on file. Patient reports normal fetal movement, no vaginal bleeding, no contractions, and no leakage of fluid. All right, this looks good. So I'm going to use the O48.0 and the Z3A41. I'm not billing this H&P because she is here for induction, basically to be induction of labor. So I'm just going to use our no charge code that we use for our OB patients for this one. And then I also think I seen a progress note. Okay, she did another note. So let me go over there and see what she did. All right, patient breathing with contractions now, would like something for pain, but complaints of some pressure, early deceleration. So that's going to be our O76 diagnosis code. And then membrane spontaneous. So her water broke, and it says fluid color meconium. So I'm going to need diagnosis 077.0 for that one. And I actually saw a cesarean delivery here on YouTube where when they broke or got into the uterus and opened up the sac, there was a bunch of like green and yellowish liquid that came out, and it looked so nasty because the meconium stain, I believe, is like a mixture of the water and then the baby's feces. It was just like, oh my gosh, to like see it, because I read it often. And when I watched that cesarean delivery, I was like, oh my gosh, that must be the meconium stain. Like, oh my gosh. I was like, I know that code. I know that code. All right, encounter patient to call with increased pressure or an urge to push. No signs of delivery yet, but we are just going to basically move on to the next note. And then I am at my delivery note. Alrighty, so I'm gonna need that O48O, Z3A41, and then she had a viable female infant, so she had a girl. And I'm gonna need Z37.0 for the outcome of delivery. So let me just read this here. And she has Blue Cross insurance, so we are looking to bill global instead of delivery only. Let me see. 3 vessels for the umbilical cord. Uterine massage performed and fundus found to be firm. Any lacerations were repaired in usual fashion using the repair suture noted. She looks like she had 2nd-degree lacerations. So that's going to be our O70.1. And what else? Admitted for induction of labor this AM for post-date pregnancy. So you always want your first or your primary diagnosis code to be the reason for the patient coming in. So yes, she had the meconium stain. Yes, she had second degree laceration, but you're always supposed, per the guidelines in the front of our ICD-10 book, you're supposed to put the reason for the patient coming in, and it was for post dates. So that's going to be my first diagnosis code, the O48.0. And then she had spontaneous rupture of membranes for light meconium stain. So I'm going to add the O77.0. The reason why I'm adding them again is because those no charge codes that I had talked about previously, I already sent those out. They're not going to go to insurance, but they're just going to be basically on the patient's account for tracking purposes only. The insurance will get this charge that I'm actually sending out, which I believe is going to be the $59400, as long as we provided her entire prenatal care. So let me keep reading. I just finished talking about meconium stain and fully dilated and pushed less than 10 minutes, delivered a viable female infant, left occipital anterior position, shoulders delivered easily, an infant to mom's abdomen. 2nd-degree laceration noted and repaired. Okay, so I have that there. So I have a total of 5 diagnosis codes. And I'm going to add her LMP here just because sometimes it needs to be on the claim. And with this delivery, it will need to be on the claim, or it's going to be sitting in another work queue telling me that I need to add the LMP. So I'm adding that now. And let me go through to check her prenatal visits out and see if we did them all. All right, and she had Blue Cross, Federal Blue Cross, and that has been affected throughout her entire pregnancy. So yay, we are billing global. Okay, that looks good. I can bill my $5,900 because it was a vaginal delivery. Usually the post-op days, they don't have any diagnosis because it's just a regular post-op day. Like she's not having any complications, nothing like that. I will use the Z39.2. On my provider's discharge, I did use the diagnosis codes that we had at the delivery, but for this post-op day 1, there was no diagnosis codes on here for me to use, so I'm going to use the Z39.2 and submit this. Okay, you guys, we have went through or gotten through my entire work day. Look what time it is. Can you see that? It is 1:40, so I have 5 minutes left of my day. Usually what I'll do these last 5 minutes is just go through my work queue and see if there's any other procedures that might have fallen in, or if I feel like doing like an NST or an IUD insertion or a quick procedure basically, or like a circumcision. I'll do those, or I'll read some emails, respond to emails. It's the last 5 minutes, baby. We all done. We are all done. So yeah, this was amazing. This was actually the very first time that I've actually talked to you guys throughout the entire day. So this was fun. I'm looking through here and I don't see anything. All right, I'm opening the op note. Oh, this is a twin delivery. Yeah, we're definitely going to do this tomorrow because the twin deliveries, I have to like really zone in and pay attention to every single detail. So that would be exciting tomorrow to review a twin delivery. I don't get them much because they usually have our residency OB providers do them, the twin deliveries. They give them the higher or more complex deliveries, but hey, my provider got a twin delivery and it's a C-section, so I will review that one tomorrow. And I'm getting ready to log out of here. Thank you all for watching this video. Make sure you give it a thumbs up, especially if you made it all the way to the end of the video. And I will see you all in my next one. Bye.